Hello everyone. I'll be taking a class on hepatitis, and for the ease of understanding this topic, the topic has been split into 3 sessions. So, as you know, itis stands for inflammation, and hepatitis is inflammation of the liver tissue. When you say hepatitis, unless otherwise specified, we tend to assume that it is because of hepatotropic viruses, that is hepatitis A, B, C, D and E virus. So, some of the other viral etiologies for hepatitis are Epstein-Barr virus, CMV, that is cytomegalovirus, and yellow fever virus. Other than these viral etiologies, some of the commonly encountered causes of hepatitis are alcohol consumption, autoimmune diseases, non-alcoholic steatohepatitis, toxins and drugs. Alcohol consumption or alcoholic hepatitis and the subsequent consequences will be dealt separately. I will be dealing with the other components here. So, when you say hepatitis, there should be certain clinical features which will make a clinician to suspect the possibility of a hepatitis. So, some of the commonest symptoms or presenting complaints with which a patient comes to the hospital are easy fatigability, flu-like symptoms, urine is dark in color. The person complains that that he or she is passing dark colored urine, and the stools have a pale colored appearance. So, and the person might complain of abdominal pain, loss of appetite, unexplained weight loss, and yellowish discoloration of the skin and the eyes. So, these are some of the manifestations of hepatitis, or these are some of the usual complaints with which a person will come to the hospital. So, coming to the autoimmune hepatitis. So, autoimmune hepatitis is a hepatitis which is chronic and progressive hepatitis. So, it is a chronic condition, that is, it's a long standing hepatitis and it progresses with time. So, when you say autoimmune, there must be a etiological factor which is causing hepatitis or inflammation. Here it is because of the immune response of the body to the hepatic parenchyma. So, and that is mediated by T cells. Here in case of autoimmune hepatitis, there is uncontrolled activation of self-reactive lymphocytes. So, these lymphocytes fail to recognize the hepatic parenchymal cells to be native to the body, and they assume that it is a foreign antigen, and so they attack these hepatocytes, causing injury, leading on to hepatitis. So, like most of the autoimmune diseases, it is common in women, and it is again broadly divided into two types, that is type 1 and type 2. And here the main antibodies that we see in autoimmune hepatitis are anti-nuclear antibody, that is ANA, anti-smooth muscle antibody, that is SMA, and anti-actin antibodies. These are the antibodies that are seen in type 1 type of autoimmune hepatitis, whereas in the other type, that is type 2, you get ALKM1 antibody, that is anti-liver kidney microsome 1 antibody, and then you have ACL1 antibody, that is anti-liver cytosol antibody. These are the antibodies that are seen in type 1 and type 2 autoimmune hepatitis. So, when you say hepatitis, there is an infiltration of the hepatic parenchyma by different types of inflammatory cells. So, here in case of autoimmune hepatitis, the one thing that stands out is the prominence of the lymphoplasmacytic infiltrate. So, there is something known as interface hepatitis. Interface hepatitis is the inflammation of the periportal hepatocytes. So, the periportal hepatocytes which are found around the portal triad, they are infiltrated by clusters of plasma cells. So, this infiltration of the periportal hepatocytes, which is known as interface hepatitis, with a predominant plasma cell population of cells, that is very much characteristic of autoimmune hepatitis. So when you say autoimmune hepatitis, this autoimmune hepatitis can have atypical presentation. So they here the hepatitis with minimal inflammation of the hepatic parenchyma, there is involvement of other organs. So involvement of other organs and the subsequent manifestation because of the other organs being affected, they might be the presenting complaint in cases of autoimmune hepatitis. So some one rare one presentation might be that of a autoimmune cholangitis. So it can present with autoimmune cholangitis where there is histologic, where we can see a histologic destruction of the bile ducts. So that is one of the atypical presentation. So what we have noticed is, unlike other hepatitis forms of hepatitis, autoimmune hepatitis is a very aggressive kind of hepatitis, and if it is untreated, there is a very high mortality. So it is around 40% of untreated cases the mortality is seen. So it is a pretty high rate of mortality. So you should be extremely careful while dealing with autoimmune hepatitis. So coming to the next entity, that is NASH or non-alcoholic steatohepatitis. So non-alcoholic steatohepatitis, as the name suggests, there is alcohol is not involved here, but still there is inflammation of the hepatic parenchyma. So that is why it is known as non-alcoholic steatohepatitis. That is predominantly caused by accumulation of fat in the hepatocytes. So there is excessive accumulation of fat in the hepatocytes or hepatocyte cytoplasm. So that acts like a trigger for further events leading on to hepatitis. So this is a part of the spectrum of diseases known as non-alcoholic fatty liver disease. So it is commonly seen in 4th to 5th decade of life. So it's you can say it's a disease of the middle age and the elderly. So it is commonly seen in 4th to 5th decade of life. A probable genetic component is also involved in this form of hepatitis, that is NASH. So a genetic susceptibility also plays a major role in individuals who are suffering from NASH or non-alcoholic steatohepatitis. So the common risk factors that we come across in case of NASH or non-alcoholic steatohepatitis are: the person is usually obese, the individuals have insulin resistance, and they will be suffering, usually this is what we notice, that they will be having type 2 diabetes mellitus. So in type 2 diabetes mellitus also there is a form of insulin resistance. So insulin resistance is a major risk factor for non-alcoholic steatohepatitis. Then you have high cholesterol and triglyceride levels. So high cholesterol and triglyceride levels, they are also a risk factor for NASH. And then you have a syndrome known as metabolic syndrome. So these are the commonest risk factors that we encounter in individuals with non-alcoholic steatohepatitis. So just a brief mention of how this NASH occurs. So basically it is described in the form of two hits. So two insults or two changes in the tissue will trigger this inflammation. The first one is the first hit is hepatic steatosis. There is a lot of lipid deposition or fat deposition in the hepatocyte. So this hepatic deposition of fat or hepatic steatosis is the first hit in NASH. So this will cause the damage to the hepatocyte by oxidative stress and cytokine mediation, which or where there is excessive cytokine release, or this inflammation which is secondary to the oxidative stress will further perpetuate the cycle of cytokine release and damage to the hepatocyte, causing hepatitis. So, it is basically two hits or two changes which are responsible for causation of non-alcoholic steatohepatitis. One is fat deposition of fat, and the next one is subsequent damage by oxidative stress and the cytokines that are released. So, for a definitive diagnosis of NASH, a liver biopsy is must. So, a liver biopsy will conclusively prove that this person is having non-alcoholic steatohepatitis. Next, coming on to the next form of hepatitis is drug and toxin induced hepatitis. So, these drugs and toxins which are ingested when it comes to drug for therapeutic means or for treatment of a particular disease, when you consume a drug that can cause damage to the hepatocyte, or in case of toxin, if a person unknowingly ingests certain toxins, they also can affect the hepatic parenchyma, causing hepatitis. So, basically they have three pathogenic mechanisms. One is direct toxicity to the hepatocyte. So, when you ingest a drug or a toxin, this drug or a toxin can directly impact, this drug or toxin can directly affect the hepatocyte, causing hepatitis. The next one can be because of hepatic conversion. So, when you take a drug, the drug is metabolized in the liver, leading on to formation of a much more potent damaging chemical or an active toxin which can affect the hepatocyte. That is the second mechanism. The third one is, so when the drug is processed, so it will generate a component which acts like a immunogenic agent or hapten. So, this hapten will bring about a response which can cause hepatic damage. So, these are the different mechanisms by which drugs and toxin can induce hepatitis. So, when the drug is administered, it can lead on to a lot of drug reactions which are again divided into intrinsic or predictable and unpredictable or idiosyncratic reactions. So, the hepatitis can be secondary to either intrinsic or idiosyncratic response of the individual to that particular drug. So, then for this kind of hepatitis, the susceptibility is more for adults than children, and women are more susceptible than men. Some of the commonest drugs which can cause hepatitis when they are administered are chlorpromazine, isoniazid and phenytoin. Isoniazid and phenytoin, you know, they are commonly used drugs. Isoniazid is an antitubercular drug, and phenytoin, it's a commonly used anti-epileptic drug. So, isoniazid is it's a part of the antitubercular regime. So, that also, when it's a commonly administered drug in a country like ours, so that can cause hepatitis, and other drugs being acetaminophen, halothane and methotrexate. These are some of the commonest drugs which can cause hepatitis. Coming to toxins, you have aminetafluoride toxin, carbon tetrachloride, alcohol and herbal preparations. Alcohol, you know, alcohol consumption can cause a lot of changes in the liver, leading on to hepatitis, which is a totally separate entity, and which has to be dealt in detail and has to be read in detail. And then you have herbal preparations. So, herbal preparations can be responsible for both predictable and idiosyncratic liver damage. So, these are some of the commonest causes for drug induced and toxin induced hepatitis. So, there is something known as the Ray's syndrome, which you should be aware of. So it is a rare and a very potentially fatal syndrome. So here what you see is a mitochondrial dysfunction, so which is commonly seen in liver and brain. So the mitochondrial dysfunction is seen in the liver and the brain tissue, where there is extensive microvesicular steatosis. So there is a lot of microvesicular steatotic change in the in this particular tissues, leading on to a manifestation known as Ray's syndrome. And what they have noticed is there is an association with use of aspirin. So when you use use aspirin in children, that is what has been noticed. They will cause a lot of mitochondrial dysfunction, leading on to this syndrome. So generally, it is advised that aspirin should be avoided in children with febrile illness. So keep this syndrome in mind, that it's a fatal syndrome, potentially fatal syndrome, which is caused by use of aspirin, or association of with aspirin is present where there is mitochondrial dysfunction in liver and brain. As I mentioned before, hepatitis, unless specified, we usually assume it to be secondary to infection by a hepatotropic virus. So among that hepatotropic group of viruses, the first virus that we come across is hepatitis A virus. So hepatitis A virus is the first virus that we'll be dealing with. So this hepatitis A virus viral infection is a self-limited viral infection. So it's self-limited, and the incubation period for this viral infection is around 3 to 6 weeks. So 3 to 6 weeks is the incubation period for this particular entity. So there is no carrier state or no chronicity if it is infection by hepatitis A virus. Carrier state, we'll be dealing with it later. So just remember, there is no carrier state or no chronic infection in case of hepatitis A viral infections. So it rarely causes fulminant hepatitis. Fulminant hepatitis is a very aggressive form of hepatitis where a significant amount of hepatic parenchyma is damaged within a span of 2 to 3 weeks. So that is what we consider. So it's a very aggressive form of hepatitis. So hepatitis A, it rarely causes fulminant hepatitis. So coming to the which classification of virus it belongs is it belongs to the picornavirus family. So it's a picornavirus family. The route of transmission is fecal-oral. So fecal-oral route is the route of transmission of this virus. And what has been noticed is, once the person gets infected, the viremia or the presence of viral particles in the blood is very transient. So the viremia is very transient. So what has been noticed is blood-borne transmission of HAV occurs very rarely. So therefore, since the viremia is very transient, the donated blood is not specifically screened for this virus. So hepatitis A virus, it doesn't cause chronicity, and the viremia is very transient. So you should remember this. And luckily, so there is a vaccine available for this hepatitis A virus, and usually when they say the immunity after you take a dose, after you take vaccination for this virus is lifelong immunity. That is what they usually say. But yeah, just remember, it confers an immunity which is there for a really long period. So as I said, the incubation period is around 2 to 4 weeks. So once there is infection or once there is entry of the hepatitis A virus into the body, you have acute diseases, which acute disease manifestation. So as I said, discoloration of the sclera and the skin, abdominal pain, nausea, weight loss. So these are some of the symptoms with which they present. So the first antibody response that we come across when there is an infection is an IgM response. So IgM anti-HAV is the first antibody which is seen, which is documented. And what the one thing that we have to be aware of is the fecal shedding of the virus. There is fecal shedding of the virus. It ends as the IgM titer rises. So just remember, the fecal HAV shedding of the virus ends as the IgM titer rises. So that was about hepatitis A. Just remember, this is the first virus that we dealt with among a hepatotropic group of viruses. So in the next session, we will be dealing with the remaining viruses.